My topic was coronary artery vasospam. The definition: we have the coronary artery vasospam, or smooth muscle constriction of the coronary artery, is an important cause of chest pain syndromes that can lead to myocardial infarction, ventricular arrhythmia, and sudden death.
Andrea, Professor of Cardiology at the Catholic University in Rome. FF means heart failure with preserved ejection fraction. This is an interesting syndrome because for many years we thought, okay, heart failure is when there is reduced ejection fraction or a severe valve disease. In the past few years we have been learning that about 50% of patients with heart failure, they do not have reduced ejection fraction, which was supposed to be the hallmark of heart failure, nor valve disease. In these patients, ejection fraction is normal, yet these patients have the same symptoms as patients with heart failure and reduced ejection fraction. And what we have been learning is that the outcome of these patients is a bit better than that of patients with reduced ejection fraction, but definitely much worse than that of patients without heart failure. The mechanisms are mainly related eventually to the fact that the amount of fibrosis in the heart increases. This makes the heart stiffer, and this is the cause of symptoms and also the cause of the alterations we can pick up with echocardiography. Echocardiography in these patients can be characterized by LVH, left ventricular hypertrophy, or impaired diastolic function, or atrial enlargement. And the diagnosis of FF is based on these two situations. First, symptoms and signs of heart failure, and then changes at echocardiography, characterized again by LVH, dilated atrium, or impaired diastolic function. When these things come together, we have the diagnosis of heart failure with preserved ejection fraction, where the main issue is a sort of stiff heart. Well, definitely this is an unmet need, because so far no treatment has been found to improve the outcome of patients with FF. And also we don't have really a validated treatment able to improve symptoms in patients with FF. Of course, we have a wide array of drugs which can be used, but no treatment has been found to systematically improve symptoms. So the symptomatic treatment of these patients is very empirical. We have to go with drugs which are likely to work. If they do not work, we go to other drugs. And eventually, in the vast majority of these patients, we get some improvement of symptoms. But when we come to the outcome, really many drugs have been tested in order to improve the outcome of these patients, but we don't have so far a successful story.
In the application in medicine, we have the coronary artery spasms indicate that there are potential problem in your heart. For this reason, your doctor will like you order a variety of imaging tests. This test can provide a clear picture of your heart and help your doctor put together a treatment plan. The following diagnostic imaging tests may be used: echocardiogram, which is an ultrasound test that uses sound wave to create picture of your heart; electrocardiogram, which is a test used to measure the electrical activity of your heart; coronary angiography, which is a special X-ray test that uses light to see inside your arteries and measure blood flow through your heart. There are many heart conditions. These tests are helpful because they can give your doctor the details that they need to make a accurate diagnosis. Once your doctor determines the problem with your heart, they can recommend an appropriate treatment plan. In the treatment, we have for a coronary artery span focuses on relieving chest pain. This may involve prescription medications, such as the following. Nitrates can help dilate your arteries and relax the arteries walls, and nitrates may be used as long-term medication or as pill to have on hand if you have another span. L-arginine is a dietary supplement that can prevent spasms. Calcium channel blockers can reduce chest thickness by relaxing the muscles in your arteries. This medication may be taken as a long-term basis. Your doctor may also want to take medication that reduce high cholesterol or high blood pressure. Taking such medication that can prevent another coronary artery span or heart attack. During treatment, you should eat a low-fat, low-sodium diet. You should also quit smoking if you smoke. This lifestyle change can further reduce your chance of getting more coronary artery spasms. Here we are the pros and cons.
Well, I think the main item is that you can't see it, and what you can't see you don't believe. Now many patients who have stable angina report, if you ask them, about resting angina as well. And often you have to ask them because their main problem is they can't get up flight of stairs, and that is really nasty because they cannot live. They are inhibited in their daily activities, and they don't really mind that sometimes at night they have a little bit of chest depression. So if you ask them, you will find a lot of them have resting angina, and resting angina of course can only be due to two things. One is coronary vasospasm, and the other thing is that they have thrombotic events like 7 times a week, which is quite unlikely. That's a very interesting question, and I don't have the answer to this. Now, when I first met these patients who reported about funny symptoms, resting angina, I thought that must be myocarditis. Why did I think that? Because they said it started 6 weeks ago on Thursday. So you never had that before? No. Now, what can start dramatically, not slowly, but like a switch on a Thursday 6 weeks ago? It can only be something infectious. And you often have a history of 8 weeks before. I had some terrible flu, I went to the dentist, I had a bad tooth, something like that seems to trigger it. Now, whether this is myocarditis or whether you have some pre-existing condition being triggered by the inflammation, I really don't know. But there seems to be some connection, and of course when you look at patients with angina and you do a biopsy, you look at the vessels, you often see some low-grade inflammation, so maybe there is a connection, but that's as much as I know. Now, that depends a great deal on where you live, because the traditions and the pathways are different in different countries. Although we pretend that we have a European guideline, doctors in Germany approach the patient totally different than doctors in Great Britain. Now, in Germany, many of these patients are being cathed on the demand of their GP, on their own demand, because they want to know what is going on, because they're afraid. Now, when you cath them, very often you don't find coronary artery disease. And we, in my hospital in Stuttgart, we perform acetylcholine testing then and try to provoke spasm. We often elicit spasm, we reproduce the symptoms, and at least we know what the patient has, which is satisfying for the doctor, but also for the patient, because he or she knows that she is not a psychiatric case, which some of these patients tend to believe because they had several caths before and they were told they were healthy. So that is for the patient who is on the table anyway. But the patient who comes to your practice and just complains about these things, you have to find out the typical features of resting angina spasm, meaning good exercise capacity, but dramatic resting angina. That's usually epicardial spasm. And then you have a mixture of complaints, patients who are short of breath when they climb stairs, but they also have some mild resting angina. This is usually microvascular. So epicardial spasm, you just think it is there, and you give the patient a calcium antagonist. You bring him back 2 weeks later and he says everything's fine. That was the right diagnosis and the right treatment. Microvascular is a little bit more difficult. You can also try to treat it, but in about 1/3 of patients there is no treatment effect, and then you're in doubt whether the diagnosis was correct. And then you can start, for instance, doing a stress echo. If the stress echo elicits the angina but doesn't show any wall motion abnormalities, microvascular angina is highly likely. And if you're a rich man, you can send the patient to have a PET examination showing a reduction in coronary flow reserve, and that makes the diagnosis.
In the process, we have the evaluation of the standard hematology, serum chemistry, lipid profiles inappropriate for excluding anemia, infection, primary platelet disorders, renal failure, hyperglycemia, electrolyte abnormalities, and dyslipidemia. Serial measurements of cardiac enzyme and troponin levels should be performed to assess for evidence of ischemia. In the cons, we have many coronary artery spasms going on diagnosis because they don't always cause noticeable symptoms. High blood pressure and high cholesterol are the most common cause of these spasms. Coronary artery spasms can also occur in people who have arteriosclerosis. This is a condition that occurs when a plaque builds up inside the arteries, blocking blood flow. High cholesterol and high blood pressure can directly increase your risk of arterial constrictions. Issue apply in Ecuador. Epidemiologic data show a wide difference in the prevalence of CAS in different countries. The CAS is more prevalent among men than women. Most patients with CAS are between 40 and 70 years of age, and the prevalence tends to decrease after the age of 70 years. The prevalence of CAS is around 50% in patients with angina and 57% in patients with acute coronary syndrome. Of note, diagnosis of CAS depends on coronary angiography or provocation test, which vary from laboratory to laboratory.
Women report more angina. If we look at populations, more women will tell you that they have angina. And this likely has to do with women and men having different somatic awareness. Women feel their bodies sooner, they feel pain more strongly than men, and they're more willing to report it. The other big difference is that women, maybe because of this somatic awareness, will more often report atypical symptoms. So within the angina diagnosis, where 2/3 of men will have typical angina, only 1/3 of women will have typical angina, 2/3 therefore will have atypical angina. So atypical angina is more prevalent in women. It is not a benign condition. It is associated in our women's ischemia syndrome evaluation study, fondly known as WISE. It is associated with an increased adverse prognosis of major adverse cardiac events, similar to 1 or 2 vessel obstructive coronary disease. Probably the most important findings of the WISE study have been the appropriate diagnosis, so detection and then diagnosis of coronary microvascular dysfunction, defined as a limited coronary flow reserve to adenosine, or defined as abnormal endothelial function to acetylcholine. In that this is prevalent over half of the women with no obstructive coronary disease, but signs and symptoms of ischemia have this diagnosis. And then number 2, that the prognosis is adverse and comparable to 1 or 2 vessel obstructive coronary disease, and therefore needing treatment. Probably the most important recommendation is not to ignore chest discomfort, typical or atypical angina in women or men. Men increasingly also have no obstructive coronary disease. It's a bit of an epidemic. So number 1, don't ignore it. Number 2, it is a vital sign. Patients with persistent chest discomfort that is not diagnosed as GERD or gallbladder or esophageal spasm likely is cardiac and should be further investigated, and then referral to a cardiologist if possible, and then diagnosis made, or treat presumptively. Try nitroglycerin or calcium channel blockers, try beta blockers empirically. If there is a good response, again, these are safe and effective drugs. This is not over-treatment for this very prevalent condition. Thank you.
In the conclusion, we have
or cardiac catheterization is an X-ray examination of the vessels and chambers of the heart, often done to identify any narrowed or clogged coronary arteries that are preventing blood from reaching the heart muscle. The study can also be used to measure the size and function of the chambers of the heart and the function of the heart valves. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor, and you may be given an oral or intravenous sedative to help you relax. Most coronary angiography procedures last between 1 and 2 hours. Before the procedure, you will be placed on a table equipped with a fluoroscope, an X-ray imaging device. During the procedure, the fluoroscope will move around your chest in all directions to record pictures of your heart and coronary arteries from multiple angles. Most cardiac catheterizations take place through the femoral artery in the groin, but can also be done through an artery in the arm. The doctor runs the skin in the groin area and inserts a needle into your femoral artery. Once the needle is placed, a wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath that permits access to your femoral artery. Next, a soft, flexible catheter will be slipped over the wire through the sheath and threaded up to your heart. Your physician will watch the movement of the catheter on the fluoroscope. You may feel pressure as the wire and sheath are inserted, but you will not feel their movement inside your arteries. To evaluate the coronary arteries, your doctor will remove the guide wire, position the tip of the catheter just inside the arteries, one at a time, and inject a special dye. This dye allows the fluoroscope to take X-ray images, called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with dye. You may feel flushed or slightly nauseated when the dye is injected. After sufficient images of both coronary arteries and their tributaries have been recorded, the catheter will be removed through the groin. Pressure must be applied over the femoral artery to prevent bleeding. You will then be taken to the recovery room for 30 to 60 minutes of observation, after which you will be required to lie on your back for several hours with a pressure bandage in place over your groin. You may either be discharged home on the same day or after an overnight stay in the hospital.
Coronary artery spasms and intense vasoconstriction of coronary artery that cause total or subtotal vessels occlusions plays an important role in myocardial ischemic syndromes, including stable and unstable angina, acute myocardial infarction, and sudden cardiac death. While the mechanisms underlying the development of CAS are still poorly understood, CAS appears to be a multifactorial disease, but is not associated with the traditional risk factors of coronary artery disease. Diagnosis of CAS has an important therapeutic implication, as calcium antagonists, not B blockers, are the cornerstone of medical treatment. Thank you.